This video will cover how to approach reading a CT chest study in terms of a search pattern and kind of the big things you're looking for. You can start off by looking at the Scout, seen here, which isn't powered like a normal chest radiograph. It's just kind of taken to localize the study. You can start off looking at it, looking for any tubes, lines, or drains, hardware, which will let you know where to expect any artifact when you're looking through the axial images. Next, switch over to the axial image. You can shift over to the lung window. You're going to follow the tree of the airway down, starting at the top of the trachea. Here you can see some bowing of the posterior section of the trachea, which indicates that there's poor inspiration in this study. Following the trachea down into the right bronchus, into some of the right bronchi, just making sure that there's no occlusions or any sort of mucus plugging, any sludge suggesting any aspirations, anything like that. Here they all look normal. You want to make sure that you're following in all your lung regions, working up into the upper right lung region as well. And then going over to the other side of the airway in the left lung, again looking at the left lower lung region, making sure that all the airways are fully patent there. Examining the upper region as well, everything looks patent and clear. Next, you want to examine the pleura, which you can start from the top. You want to break your lung regions into roughly 6 sections, bottom, middle, and upper for both sides. You want to follow the pleura down, looking for any abnormal lung findings, looking for any sort of hemothorax, pneumothorax, any fusions with loculations or any plaques, and everything looks normal here. And looking at the upper region as well, everything looks normal in the upper right lung as well. Looking at the left lung, again going back down to the lower section, everything looks normal in the pleura. Working my way up to the top, everything looks normal as well here. After you're done examining the pleura, you want to look at the lung parenchyma itself. And here you want to break it off into 6 sections again, upper, middle, and lower region for each lung. Starting in the right upper lung, the parenchyma looks normal. Then moving on into the middle section, everything looks normal here as well. Scrolling through. And here in the right lower lobe, you see some gravity-dependent ground glass opacities at the bottom of the right lung. The differential for ground glass opacities in general is pretty broad, but you want to look at the patient as a whole to figure out what is going on. As we saw earlier, of that poor inspiration, which you can see in the trachea, that alongside the fact that this atelectasis is gravity-dependent in the bottom section, probably just poor inspiration causing atelectasis in the basis of the lungs. However, if this was more centrally distributed, I might think it's more suggestive of pulmonary edema, or if it was more randomly distributed, maybe it'd be something like a pulmonary hemorrhage. But here it looks pretty benign, probably just some gravity-dependent atelectasis. Going over into the left lung, you can see similar atelectasis at the bottom of the left lung. Going into the other lung sections, everything looks normal as well. Next, you want to switch over to the MIP window. This is a stack of multiple consecutive images that helps you visualize some smaller things. You want to scroll through for anything that seems like it's coming in and out and not following the vascular tree. If you think you may see a nodule, you want to go back to the regular window. Here, I thought I may have seen something, but I went back to the regular window and I didn't see any nodule. Scrolling through again, looking in your 6 sections. Over here, it looks like there's a small nodule, so I go back to the regular window and scrolling back and forward, you see that there's a nodule that comes in and out of view, not respecting any vascular tree. It looks pretty small, 2.6 millimeters. Whenever you find a nodule, you can use the Fleschner criteria as long as the patient meets the inclusion criteria to think about next best steps for follow-up imaging. Going back to the MIP, working my way through the rest of the image, looking at that middle lung region on the right lung, everything looks normal besides that one nodule. Same thing for the right lower lung. Walking through, everything looks normal here, no nodules. And then hopping over to the left lung, same thing, starting at the top lung region, looking for any nodules, anything that comes in and out of view. Here it looks like there may be something, but it's kind of following along the line of an airway, so it's probably just part of the lining of the airway. Looking for any other signs of nodules in the lung. Looking at the middle region now. This looks fairly normal. And then the left lower region as well. I'm not seeing any nodules present here. Next, you can turn off the MIP, go back to your regular window, and just follow the contour of the pulmonary artery down, looking for any of filling defects just above an emboli. This isn't a CTPA study, so the slice thickness isn't thin enough to really get good definition on all the subsegmental arteries. We want to look at the segmental ones at least. And while you're in the lung window, you want to quickly just scan the abdomen looking for any free air because air is best seen on the lung window. Switch back to a soft tissue density and look towards the axilla. Here you're primarily looking for any abnormal lymph nodes, looking for like enlargement greater than 1 centimeter in the short axis, or any calcifications, or any other signs like loss of a clearly defined border or necrosis. And here they look fairly normal. If you're not sure if they look normal in terms of SATS criteria, you can always measure them. Here, this one is less than 1 centimeter. After looking at the axilla, you want to work your way along the chest wall, both looking at the musculature and the subcutaneous tissue. Just working your way around the chest, up and down, again, breaking it into manageable chunks, examining one section at a time. Primarily looking for any sorts of masses, any like edema, emphysema in the subcutaneous tissue, any fat stranding. If the patient has breasts, you also want to make sure to examine them at this time for any obvious masses or calcifications. Then going to the posterior section of the chest, again, scrolling up and down to the soft tissues, just looking for any obvious abnormal findings. And then working my way back into the left axilla. Here you can see that there's this fat density area that isn't supposed to be there. You can always compare left to right because they generally should be the same on any imaging. And here you see this area that's not there on the right. And if you're not sure about the density or what tissue it is, you can always check Hounsfield units. Here it's around negative 100, similar to other subcutaneous fat tissue, indicating that's primarily fat. Differential for something like that, given that it's pretty well circumscribed, is something like a lipoma. However, given how deep it is, lipomas are typically more towards the surface, given that it's kind of within a muscle belly. It could also be a hypernoma. Going back to looking for lymph nodes, here you can kind of look at the subcarinal area, looking for any enlarged lymph nodes there. Looking for any other enlarged lymph nodes, and I would recommend using a source such as Radiopedia to kind of familiarize yourself with where the typical lymph nodes are. Be careful not to mistake any of your typical findings in the mediastinum for lymph nodes, such as the esophagus or the azygos vein. Here you can see the azygos vein coursing, not just appearing as one enlarged soft tissue density in one slice, but coursing into the SVC. Next, you can work your way down to the heart, where you can assess the 4 heart chambers for any dilation using the 4-5-4-5 rule. Starting clockwise from the bottom, the left atrium should be less than 4 centimeters in the AP direction. The right atrium less than 5 centimeters in the transverse direction. The diameter of the right ventricle should be less than 4 perpendicular to the long axis of the heart, and the left ventricle less than 5 in the same direction. You can also assess either the interventricular septum or the free wall for any thickness suggesting hypertrophy. It should be less than 18 millimeters thick, although you want to make sure that you're assessing this in diastole, not systole. Find the mitral valve, which is typically the easiest way to assess if it's in systole or diastole. The mitral valve is open, indicating that it's in diastole. Next, you want to look at the great vessels. You can look at the diameter of the aorta and the pulmonary artery. You want to look at these kind of right before the pulmonary artery bifurcates. Make sure that they're less than 3.5 or 3 centimeters, respectively. You also want to examine the aorta for any intimal flaps, false lumens, or aneurysms anywhere along its length. Typically, the easiest way to do that is in a coronal view, where we can kind of see the ascending aorta in one go and then the descending aorta in another go. You can kind of just measure the diameter where it's thickest to make sure that there's no aneurysm. Next, going back to the axial view, there are a couple other areas that you want to make sure you're looking at, otherwise you will miss findings in them. One being the anterior mediastinum, making sure there's no masses, kind of thinking of your four terrible T's. Then you also want to make sure you're going up to look at your thyroid, examining its contour, making sure there's no nodules or masses present. From there, you can follow the contour of the esophagus down from the throat to the stomach, looking for any perforations or hiatal hernias. Here you do see a small hiatal hernia. You see kind of the esophagus getting bigger before going through the diaphragm to the JE junction into the stomach. That little outpouching would be a hiatal hernia. You can also typically see them better on either a sagittal or coronal view. Here you can see kind of that ballooning of the esophagus above the diaphragm, indicating a hiatal hernia. Next, you want to switch over to the bone window, and you can use whichever view you prefer here to examine the bones, whether that's axial, I prefer sagittal. We want to start by looking at the spine, looking for any lesions, fractures, or degenerative changes. Here you see some osteophytes and some pretty well-defined changes in the border of the bone, which likely represent Schmoll nodules. They're well circumscribed, round, and right in the center of the end plate, all kind of within the spectrum of degenerative changes. Next, you want to view the ribs, and again, you can use either a sagittal or an axial view, whatever you prefer. You want to make sure you're following the length of each rib, looking for any fractures, whether it's acute or chronic, or any lesions. And just kind of follow along the length of all the ribs here, going backwards and forwards. Everything looks fairly normal. No findings thus far. Then going over to the other side. Again, following each rib here, everything looks normal. Here you see a potential irregularity, which isn't that well viewed on this view. So I'll use the localizer and switch to an axial view to see it better. And here you see this increased density in the bone with everything fairly well defined, likely just represents a chronic fracture that's healed. And then following the rest of the ribs, everything else looks normal as well. Then you want to make sure you're looking at the rest of the bones you can view as well. The sternum, everything looks normal here, as well as the scapula and the clavicle. And we can see the humerus.